I'm Ann O'Day from the University of Kansas Cancer Center. I'm a breast oncologist here, and I'm so honored today to have a very esteemed board of presenters for you all. I'm going to ask that they each just introduce themselves. I think maybe we'll start off with Dr. King.
My name is Terry King. I'm the chief of the Division of Breast Surgery at Brigham and Women's Hospital and Dana-Farber Cancer Institute. And it's a pleasure to be here with you and with all of my colleagues today to discuss these cases.
I'm Chirag Shah. I'm the Director of Breast Radiation Oncology and Director of Clinical Research at the Cleveland Clinic. It's a pleasure to be with all of you this afternoon.
Mark Pegram. I'm the Associate Director for Clinical Research at the Stanford Comprehensive Cancer Institute in Palo Alto, California. Thanks for inviting me to participate in today's tumor board.
Hi, I'm Maxine Jockelson, and I am the Director of Imaging at the Breast and Imaging Center at Memorial Sloan Kettering Cancer Center, and I am both a breast imager and a PET reader. And I'm really thrilled to be back doing this conference with you.
So our first patient today is going to be a 50-year-old woman that has recurrent and metastatic triple-negative breast cancer with bone, nodal, lung, and skin metastasis. She was originally diagnosed in 2008 with DCIS, which was ER and PR positive, but subsequently diagnosed with a triple-negative left invasive ductal carcinoma in 2016. She has been on multiple lines of treatment, currently on sacituzumab govitecan since July of 2020. And we're going to be focusing on sort of the next recommendations for treatment following progression. Her oncology history starts in 2008, at which time she was diagnosed with DCIS, which was ER and PR positive. At that time, she underwent lumpectomy followed by adjuvant radiation therapy. She declined adjuvant endocrine therapy and had negative genetic testing. Then in 2016, she was diagnosed with an infiltrating ductal carcinoma of the left breast, which was grade 2, which was triple negative. At that time, she underwent bilateral mastectomy with sentinel lymph node, which was staged at a T2 in 0. She completed adjuvant chemotherapy with Doxorubicin, cyclophosphamide, followed by paclitaxel. And in 2018, she appreciated skin changes in the left nipple-areolar area. An MRI demonstrated enhancement suspicious for cancer recurrence, and a punch biopsy demonstrated metastatic carcinoma consistent with triple-negative breast cancer. She then, in 2018, had a PET scan, which demonstrated 2 hypermetabolic axillary lymph nodes. A biopsy of the axillary lymph node was consistent with metastatic carcinoma. In June of 2018 through December of 2018, she received carboplatin and gemcitabine. And in December of 2018, CT scans demonstrated progressive disease. In January of 2019, she was initiated on eribulin, and then in May of 2019 was unfortunately found to have disease progression, at which time her therapy was changed to nab-paclitaxel. She had PD-L1 testing at that time, which was 0%. In October, she had progressive disease, and in November, subsequently enrolled in a clinical trial at MD Anderson Cancer Center with intratumoral injection of an investigational agent. Then she had progression noted after one 28-day cycle. At that time, she was started on capecitabine and had subsequent progression in July of 2020. At that time, imaging demonstrated a new nodule in the lung, and her treatment was switched to sacituzumab govitecan. In February of 2021, she had CT scans which showed stable disease in the sternal metastasis and lung nodule. And so the question that we are faced with is kind of what would be the recommendation for treatment with next progression? So if Dr. Pegram, do you want to sort of start us off and give us your thoughts about that?
Sure, I'd be happy to. The first thing to recognize is this is a young age patient, relatively speaking, 50. And while you mentioned her BRCA1 and 2 tests were wild type in terms of her germline genetic testing, she didn't have any other genes in the homologous recombination repair pathway tested, for example, CHEK2. So I would do panel testing with oncology genetics to test a larger suite of DNA repair genes to see whether she might have an inherited predisposition for her cancer. And also it's been shown that CHEK2 is responsive to PARP inhibition, for example. So that would be another reason to check the germline. The second thing is to consider, mutational analysis with next generation sequencing, for example, with Foundation Medicine or with Tempus, because these genomics panels may offer some other clues as to salvage therapy options, including investigational clinical trials that she might qualify for, depending on what type of molecular alterations are found in her tumor. Moreover, some of these panels include other parameters like tumor mutational burden and microsatellite instability, which might predict for response to checkpoint inhibition. I know she's already been tested for PD-L1 and was found to be a negative, and she did get an immune checkpoint inhibitor on that clinical trial, but it was investigational and it was in combination with a STING agonist that's given intratumorally. And so that is not yet, FDA approved. It's investigational. It's not a chemotherapy combination with immune checkpoint inhibition. So we haven't completely eliminated the possibility of considering immune checkpoint inhibition, for example, with a chemo combination, if she were found to have high tumor mutational burden or microsatellite instability. Otherwise, it's really, chemotherapy is the standard of care in this setting following progression on sacituzumab govitecan. And there are some agents that she hasn't had. She's had a lot of chemotherapy already, however, capecitabine. She's already had carboplatin and gemcitabine. She's already had eribulin, sacituzumab govitecan, the TROP2 directed antibody drug conjugate. She's had AC, she's had paclitaxel. But there are a few more that she's not had, and that includes Vinorelbine, for example, Docetaxel, liposomal Doxorubicin, et cetera. And then, as I mentioned previously, eligibility for phase 1 clinical trials should be assessed in her case. And finally, it didn't say specifically in the narrative whether she had had a bone-acting agent for a bone metastasis. I assume she's either on a bisphosphonate or antibody therapy for bone metastasis.
Yes, thank you for pointing that out. And also, it was mentioned by the submitting physician that there is some skin involvement. And so if Dr. Shaw, could you just comment on the role for radiation for patients that are having recurrences with skin involvement?
Absolutely. This patient received radiation in 2008, likely more standard treatment for 5 to 6 weeks. And patients are often told that they can't get a second course of radiation having previously received radiation. But we've actually seen extensive series where patients have disease limited to the skin or the skin and axilla or sternum, which this patient has had, and now she does have some other disease as well. We would consider giving her reirradiation. And also including hyperthermia to enhance the radiation sensitivity for these skin lesions. This patient's already had capecitabine, but capecitabine can also be added to this. And there's multiple different regimens, including hyperthermia radiation given twice weekly for 4 to 5 weeks, or daily radiation to higher doses with hyperthermia twice weekly and capecitabine for limited skin metastases as well. These patients actually do pretty well in terms of toxicities. The rates of long-term toxicities of the radiation are low, though they do develop significant desquamation towards the end of radiation therapy.
Okay. Could you comment about how the hyperthermia adds to any toxicity for the patients, and what's been your experience with that?
Yeah, so hyperthermia actually allows us to typically use lower doses than we would normally in a definitive setting. There was a nice study out of the Netherlands that looked at recurrent breast cancers, and it compared basically radiation alone to radiation with hyperthermia, and better responses were seen long term. In terms of the side effects of hyperthermia, we do tend to see a relatively brisk erythema and kind of skin peeling, which is consistent with radiation and hyperthermia. But beyond that, the toxicities are low. And in published studies, the rates of grade 3 toxicities long term are under 15%.
Okay, thank you so much.
I have to say that years ago when I was in Boston, we used to use hyperthermia in these patients, and they got great responses. And there were some early data from Stanford where there was actually a prolongation of survival if patients just had locally recurrent disease, if they did get hyperthermia after having had radiation in the past.
Thank you so much, Dr. Dockelson. I appreciate that.